In our first STS TV Science Spotlight, we're highlighting a new study examining complex aortic arch reconstruction. Dr. John Spratt authored the study, and he's here with his findings. Thank you for joining us. I appreciate it. Dr. Spratt, please give me a definition of extended arch reconstruction and explain the difference in reconstruction procedures that your study compared.
Sure. So when folks have aortic dissection that affects the ascending aorta, we typically treat that as a surgical emergency, or we do treat it as a surgical emergency, and that's typically addressed in the operating room on an emergent basis. And so the goals of an operation like that, number one is to save the patient's life, because this is often a very morbid diagnosis that folks can have. Extended arch reconstruction is an umbrella term for a wide collection of procedures that is a little bit more of an advanced arch reconstruction than what I described a minute ago. It typically involves resection of a bit more of the aortic arch. We would sew the arch a little bit further back into the chest than we otherwise would. And then you also will reimplant or reconstruct the origin of one or more of the blood vessels that go to the head and to the arms at the same time. And then depending on the situation, we'll sometimes actually take an aortic endograft and deploy that into the open arch, which can help to prop open the aorta from the inside and cover a complex tear or an aneurysm or something like that. That can be necessary if folks have something like a complex arch tear, a connective tissue disorder, or some known distal arch pathology that needs to be taken care of at the index procedure. But it can also be a nice option when those things aren't present, because it can set folks up for success in the future. Because about a third of patients that have these aortic dissections will develop aneurysms or other distal aortic pathology that traditionally requires more open surgery, often through the side, to repair. But if we can get them set up on the front end in such a way that they can have endovascular management of those issues, then that can be a better option for them in the long term.
As you studied these different surgical approaches, from everything from an emergency situation to a preventative situation, what did you find? What were the results of your study?
Yeah, so the thing that we were really interested in was determining if there was an advantage to doing these extended arch reconstructions in older patients that have aortic dissection. And so the STS has this ability to use its adult cardiac surgery database linked to Medicare data. And so that allows us to look at long-term outcomes in patients over the age of 65. And I was personally just wondering, what is the benefit of doing these more advanced arch reconstructions on older patients? And do they get the same degree of benefit that younger patients might? And so what we found overall was that there actually wasn't much of a difference as far as our main outcomes of interest, which were overall survival, and then the rate at which they underwent additional aortic procedures over the long term.
Let's talk about the data. How vital was the STS database to your research?
It was extremely important in doing that. And so the way that this question is usually looked at is single center data from high volume aortic programs. And so those data are always going to be very good. They come from experienced programs, and the results that get reported are typically positive. What the STS data allows us to do is look at data that comes from basically every program in North America that does heart surgery. And so you can't really hide, and all the results are going to be there. The STS data itself gives us high quality information about the patients themselves and anatomic detail about the procedure that's performed. And then the ability to link it to Medicare data gives us more long-term information about a patient's vital status, and then also whether or not they end up undergoing reintervention because of the billing data that gets captured as well.
Sounds like it really widens the scope there. Very good. So what's your hope? What do you want to have these results? How do you want to see them play out in this patient population of adults over 65?
Patients who are undergoing this surgery for this difficult problem, we all know that the most important priority is to bring a living patient to the ICU and then subsequently get them home again. And so surgeons that work in high volume aortic centers and do a lot of extended arch reconstruction, it's, I think, perfectly fine to continue doing that, because we show that there's not a significant, penalty with regards to short or long-term outcomes that go along with that. On the other hand, surgeons that don't do aortic surgery every single day, or don't do a high volume of dissection and only take care of this problem a few times a year, I think they can also be assured that just doing a good hemiarch is a perfectly acceptable option, and that it doesn't have any long-term penalty to the patient as far as a higher rate of needing surgery in the future, or worse long-term survival.
This is just a snippet of what people will see at your presentation. Tell us, when and where are you speaking here at STS?
I'm speaking at 11:15 on Sunday morning.
Thank you so much for joining us today, Dr. Spratt. And again, if you want to see his full presentation, that's 11:15 on Sunday.